Hi, Philip, and hi, James.
Hello.
Hi, Nagi.
Hi. So I'm actually, it's very unfortunate. I had to be in Hong Kong. In fact, it's been such a long time that I wanted to be desperately there, but unfortunate circumstances that I couldn't make it.
We miss you.
Anyway,
We miss you.
I miss Hong Kong and all of you too. But anyway, circumstances are different now. Uh, so basically, we have today transmission of, we have very interesting cases lined up, but probably we have time for two cases, but we have many more if time is there. Uh, what we're going to demonstrate is one pancreaticobiliary case, ERCP case, and the second the case of a reflux with using GERDX. So we'll start with the history of the first case before we actually go into this
Yes.
procedure.
Please.
So this was a 64-year-old female patient who came with obstructive jaundice and abdominal pain of 1 week duration. Her liver function tests were abnormal with raised bilirubin, abnormal enzymes, and a TLC count which was fairly normal. An MRCP showed caliculae in the middle and distal CBD causing upstream bile duct obstruction, a thickening of the distal left hepatic duct in segment 2 and 3 with intraductal caliculae. She had an attempt at ERCP in another hospital elsewhere. A sphincterotomy was done, but they couldn't clear the stones completely. The objectives for this case are, of course, biliary cannulation will be relatively easy because of the previous sphincterotomy. Endoscopic approach remove little difficult, and especially with intrahepatic. And after the removal, it's very important that we check the intrahepatic ductal system, mainly because an association between so-called cholangiohepatitis, carcinoma, and so on. So what we are planning to do now is to go ahead, cannulate, and then, so I'm already in the second part of the duodenum, if you can actually see this. And we have, I think, if you can look at the papilla, there's some contractions here. Working with me is Dr. Santosh, who is already well known to everybody there. He is chief of anesthesia, and Mr. Nageshwar Reddy, our technician. So this patient is on a prone position, and are the images clear there, Philip, James?
Yes. We can hear clearly.
Yes, very nice pictures
What about
as
the
well.
image quality is okay?
Yes.
Yeah,
yes.
excellent.
Oh, thank you. So we now have to probe and see where exactly, it's somewhere here, opening here. So I'll just ask the Srinivas to bend the sphincterotome a little, and we do wire-guided cannulation. So we are using a Terumo wire now first. We've gone deep into the CBD, and we'll try and now inject contrast. Very high up, I like to inject the contrast. We are now in the right anterior duct. There is a filling defect in the CBD. Can you inject more contrast? Like I can see the gallbladder filling up now. And now I'm trying to see if there is nothing in the right duct that I can make out very clearly, but I'll inject some more contrast there. Inject, stop. I can see the right anterior duct there, and I can see the left taking off. So I'm going to come down and see if I can go into the left relatively, selectively, to see if I can get, I think we'll have to go into the left ductal system now. That is still in the right. So I'll come down a little, come back, wire back, and then see if we can go into that. See, what I'm doing is I'm hitting against the wall, and the guide wire is then pushed to the left side. Can you see that technique that we use?
Yes.
The technique is to bend the sphincterotome, hit against the opposite wall. So I can see some duct, some caliculae in the left duct also. So we'll have to now, can you push some contrast? Srinivas is going to give some more contrast there. The right seems to be okay, but the left there are duct, but these are little floating stones. So basically now what I'm going to do is I'm going to come back and do a balloon sphincteroplasty. Yeah, we'll do a balloon sphincteroplasty of this, and then I can see the multiple stones there. We'll change the wire. So our policy in the department, Philip, and is to use a Terumo wire first as a pathfinder. With the Terumo wire, we can very easily go into so whatever duct you want. As you can see, we can manipulate the angled Terumo wire. With the regular wire, we can't do that as easily. But once the Terumo finds us the path, we would then do a standard wire. I'm now using a 025 VisiGlide wire to get deep into the ductal system. I'm going to use a CRE balloon from Boston Scientific to dilate this. Now, how much to dilate? The lower end of the CBD looks about 10, 12. So I think I can go up to 12 millimeters with this. So I'll use a CRE balloon to dilate it. We'll put a little contrast also in the CRE balloon to visualize it better. And when we reach to that point where the waste completely goes off, there is a controversy how long to put, just waste is enough and so on. Our policy is to use at least 60 seconds. So we clear the waste and use 60 seconds to see it's completely opened up. And of course, there are other balloons that are available. My preference is the standard CRE balloon. There's a balloon called the precision balloon, which is specifically used for sphincter dilatations, but there's not been much studies on this. But I think the standard CRE is good enough in most cases.
Nagi.
Yeah.
Yeah, may I ask your approach of nowadays you have sphincterotomy by the conventional way or sphincteroplasty? How do you choose between these methods?
Yeah, that's a very good question, Philip. So what we do is, if the patient has a stone which is 1 centimeter or less, we do a conventional sphincterotomy. The patient has a stone 1.2 centimeters or more, we always do a combination of sphincterotomy and the sphincteroplasty. If the patient has a large stone more than 2 centimeters, we do a sphincteroplasty, but combine it with cholangioscopic laser or EHL to break the stone. We very, very rarely do a isolated sphincteroplasty. The indication for that would be coagulative disorders or in patients who have cirrhosis sometimes, in patients who are on antiplatelet drugs which we can't withdraw. In this type of situation, we would do a plain sphincteroplasty, but very rare. So always mini sphincterotomy, that is 5 millimeter sphincterotomy followed by sphincteroplasty. Occasionally, only large balloon sphincteroplasty in those with coagulative disorders. That is very rare because incidence of pancreatitis increases. In these cases also, I put in a pancreatic stent before I do this. And of course, isolated only sphincterotomy for stones which are 1 centimeter or less. So this is the policy. Philip, that answers your question?
Yeah, I think we can read your mind by that. And I think it's very important we have a selective approach
Yes.
to according to different pathology, especially the stone size.
Yes. So you see the balloon is dilated now, the CRE balloon that we're using completely. The waste is gone. It's up to 12 millimeters based on the pressure here. The reason why we keep it for 60 seconds is for two reasons. One, of course, we believe that you dilate it with this at that point, so you break all the fibers. Second, when there's a bleeding or a mild ooze which can occur with this procedure, if you put it longer, it's always better. So what I'm doing is now I'm going to deflate, but when I deflate, you see what Mr. Srinivas is going to do is to deflate stepwise. We don't deflate it suddenly. We do it stepwise so that if there's any bleed, it sort of comes down in a stepwise fashion. When you see the bleed, then we re-inflate again. So that's the reason why we are slowly deflating it, not suddenly. And this is a very important point. People do a very sudden deflation many times, and if they see some ooze, they get confused and so on. Whereas this is more controlled. You can see now, it's nicely dilated. Philip, you can see through into the CBD.
Yeah, very nice, very nice. Very sizable sphincteroplasty.
Right. So what I'm going to now do is also, it's very important that we aspirate all the contents from the balloon because it's difficult to pull it out from the channel unless everything is aspirated. So we're doing that now, putting the guide wire in place, and fortunately the guide wire is still in the left duct for me, and you can see the nice sphincteroplasty that we produced. Because this patient already had a partial sphincterotomy, it becomes easier. If we didn't have that, then you don't get such a nice opening like you see here in this case. So what we are going to now do is to pass a stone extraction balloon. I'm using a Boston stone extraction balloon, which again is like a CRE balloon. You can have a differential increase in the size. So I'm going to use that to go through completely up to the second. We now have the wire very deep in. But the principle of removing stones in the bile duct is to go to the distal stone first, remove that, and then go above after that. So I'm going to use that. and I'm going to go up, yeah. So this is in the mid part, and that is where the lower stone is. I'm inflating above the lower stone here, and then I'm going to pull back. And what I'm going to, you can see, it's come out very easily. So I have to, there's some clot-like thing that's come out also. But anyway, I'll go deeper in now to get the stones, the distal stones out. Yeah, inflate. I'm inflating there. And then the principle is that when we come to the lower end of the CBD, we don't, again, another stone has come out, but in this blood clot, you don't see it so well. So the principle is that we have to not pull out the balloon directly. I'll show that to you when I'm getting the top one out now. Inflate. Yeah, I'm getting this into the CBD. And as I come in the lower part, I just hold the balloon. You can see the floating stones below. So how I hold the balloon this way, get it to the bottom as much as possible, and then push my scope down and turn to the right. So then we can get the stone out in this case. So you see, the stones are already in the blood floating. So I have to convince you that I've removed that by showing you. James, you're convinced?
Yes, yes, it's in the distal duodenum, isn't it?
Because you're generally skeptical of my procedure, so I thought I'll convince you first. Yeah,
well,
so
I can see them very clearly.
Yeah.
I can even see through the clots.
Yeah, okay. So we go, I'm trying to see if I can go above that area where there's some segment which is very abnormal. To see if I can sort of go in, and then, we are above that. So I'm going to, this is a segment which is described little thickened on MRCP. So I'm going to pass the balloon, and once I do that, what I'm planning is I'll put in quickly a cholangioscope to see what is in that area. I think it looks like we have cleared all the stones according to me. I don't want to inject too much contrast, because when you inject too much contrast, the view on cholangioscope is not very good. So we'll remove this balloon and quickly put a cholangioscope, go into the left hepatic ductal system to see if we find anything. You'll also notice that we are putting the cholangioscope on the guide wire. You can do it without that, because the present DS2 is very easy to use. It's got a beveled edge and so on. But when you have a guide wire, why not use it as well? So this is the scope going on. The DS2, of course, images are fantastic. The audience there, I did not have to tell them about the new SPY scope and the new SPY bite that has come, which is also SPY Max, it's called. You get a fairly significantly larger biopsy tissue with that. So if you see anything in the left duct, we'll take a biopsy. Otherwise, I want to be very sure that we are cleared completely. You see these pigment stones that were there in this patient. There's an association between this and oriental cholangiohepatitis and cholangiocarcinoma in our part of the world. So that's the reason why I want to do this very carefully. I'm now going into the technique is, again, for those who are not using this SPY so much, to go very close to the papilla, and then I'll ask my assistant Srinivas to pull it up a little, angulate it up a little like he's doing now. And then once it goes into the CBD, I turn my knob to the right, fix it, and then I take a proper angle here. Just pull back, and then you're in the CBD. So now what I'm going to do is, I'm going to switch the big screen to the cholangioscope, and as we go in, I'm going to put in some water. I hope you're getting the picture of the cholangioscope. Yeah. So now I'll make it tie it off onto my duodenoscope so it becomes single operator. Some people do it as a dual operator, but it's easier this way. The most important principle is, again, if the camera can focus here, is to actually fix it halfway. The knob is fixed halfway so that you can turn the knob, but still they won't fall off. So you can put whatever way here. You can see the cystic duct opening there. Can you see, James?
Yes, very nicely, yes.
Yeah, so you can see that. So now I'm going to use both fluoroscopy and a combination of now I've got into the hilar region, and I'm in the left hepatic duct. On the right, you can see the right hepatic duct also there. So I'm going to go selectively, because left was one where the pathology was, and I'm going to go into the left hepatic duct. You can see the subsegmental branches there. I have to clear it a little bit more. We can also aspirate. There's some bleed which is there. So it is not from the sphincterotomy side, but there's an abnormal area. There's a stone there. Can you see that?
Yes.
Stone there. So this was not clear. What I'm trying to see is if beyond the stone if there is a stricture. So there's this mucosa is also very abnormal. I'll take biopsies also from this before I remove the stone. But this is an abnormal mucosa. So I want to be sure that we are not missing any neoplastic process here. You can see this? Can you see that area, James?
Yes. We are not convinced that this is abnormal, but this could be inflammatory changes as well.
Exactly. No, I agree with you. This could be inflammatory, not neoplastic, because the stone's lodged there. But I think a biopsy would be essential to get at it. The stone also is probably a small strictures area there. That's why it didn't come out so easily. The guide wire is beyond it. So what I'll do, I'll take biopsies that with this using the new SPY Max by SPY Bite. Just to show you with SPY Bite quickly, we'll take off the guide wire. And then I'll use probably a laser to break this. After we take the SPY Bite, we'll move to the next room where the Gerdex is ready because we just have another 10 minutes. So
Okay,
you can see that before I'll complete the procedure here and then get back to you with the thing. So can we have the SPY Bite? SPY Bite Max is a new one which has got a jaw which is bigger than the old SPY. And the quality of the biopsies we get is quite higher with this. Yeah, this is the one. You can focus a little more on this. Yeah. The problem for us, of course, is the cost involved because this is much costlier than the older one. But anyway, of course, I think all good things are costly.
Nagi, do you have problem pushing the device up? Sometimes it's difficult to push it up.
Exactly. Yeah, so that's a very good point. This is a little easier SPY Bite, but sometimes we find it difficult when it comes to the elevator. You can see here it gets stuck at the elevator here. But fortunately, this comes out. Can you see that, James? It came out quite easily. And this is one of the characteristics of this, I think, SPY Bite. It somehow moves easier. I don't know why, but if we get stuck, we do two movements. One is push the cholangioscope a little more in, push the forceps because you're bypassing the elevator. Or another small trick is to keep opening and closing the forceps little by little. Then it goes inside easily.
Okay.
Okay, so I am now near that abnormal area, and you can see very nicely open. You can see the SPY Bite opening there. And I take a nice biopsy bit here. Close. So I'll do this and I'll tackle the stone. Probably you might have to use a little laser there to break it into pieces before it comes out. Meanwhile, you think we should shift to the nether room because we have only about 10 minutes for another interesting case. We can see very nicely the stone there. If the camera can show that, you know, it's this is an abnormal area. And James, you may be right. This looks more fibrotic rather than neoplastic. You're always right, James.
Yeah, thank you, Nagi. We move to another room. Very nice demonstration. Excellent, as
Thank
usual.
you.
Yeah,
Thank you.
Thank you. We'll move to the next room where Dr. Rakesh is along with Dr. Asif. And they're going to demonstrate this procedure of Gerdex, which we are doing quite frequently. And we have a recent RCT on this. Can you move to the next room, Satya? Rakesh, you're on.
Hello, Professor James and Professor Philip.
Hello.
Thanks for the opportunity. Hi. So can I have the slides before I start? So as you see here, she's a 43-year-old female, came with refractory or PPI-dependent GERD from past 2 years. And the manometry evaluation showed a normal esophageal body motility with high volume reflux episodes on pH impedance. So we are going to show you the endoscopic full thickness fundoplication with a device called Gerdex. And also we are going to discuss on the selection of patients and contraindications of this. This is the recent publication from our group in GUT 2022, where we did a RCT comparing this device with a sham control, where we have found significant improvement in the quality of life and also statistically not significant, but good improvement in the PPI independency. So as we go on into the procedure, I want to show you on the screen. So this is the device which it looks like externally. I'll explain in brief about the device and then go to the procedure. As you see here, this device has got a handle and a shaft with a distal 2 pledgets on which you put the sutures. So the beauty of this device is it's a very automated device and then very easy to do with utmost safety. As you see here, it has got a joystick kind of device which you can hold like this with a lever which is used to open and close the distal ends of the device. As you see here, this is how it opens. You put the pledgets and then close for the plication. So there are 3 components here, the close, open, and fire mode through which it acts as. And you also have a lever which is used to retroflex the device and then straighten it. So this is how it looks. And the shaft typically is around 17 to 18 mm in diameter. And also you have a lock-in mechanism. Another 2 important points are, there is one on one end, you get the helix which is used to grab the tissue. And on the other end, there is a channel through which the pediatric scope, the slim scope passes through the 6.5 mm channel. So this is how the device looks. And now we'll go into the procedure per se. For me to assist, I have Dr. Asif with me, who is my third eye, who has put this scope already into, and then he's going to guide me what I'm going to do. And I have my anesthesia team who have intubated this patient on a general anesthesia with a supine position. And I have the tech team who is going to assist me with Madhu leading it. So now as you see here, I have retroflexed the device. And can you show them the fluoro picture once? So as you see here, both my device and the pediatric scope are retroflexed. And with the pediatric scope, I have a view of what I'm doing. So what I'm going to do is, the main selection for these patients is Hill's grade 2, high volume reflux episode, small hiatus hernia, and PPI dependent GERD. So now the first step, what I'm going to do is, I'll go to the open mode, if you can concentrate on the device, and then I'm going to open the eagle claws as you see here. So my primary aim will be to go near to the greater curvature. Can you push it? Yeah. And then lock the device. As you see here, the helix is out, which is going to grab the tissue. I'm going to rotate 3 or 4 revolutions and then get the tissue inside, okay? Lock it. So now what I'm going to do is go to the close mode. Can you deflate? My main aim will be to get maximum tissue in between the 2 pledgets. And then once I get the maximum tissue, I'm going to operate and then adjust myself. Now, once I go and feel that there is good amount of tissue grabbed, then I'm going to go to the close mode. Can you inflate now? And close. So as you see here, I have closed, and now I'll go into the fire mode. Can you inflate? So for inflation, as you see here, I'm using a simple sphygmomanometer cuff, which has got external channel to this device, which is used to inflate. Now, once I inflate, I'll go into the fire mode, and if you can see my fingers here, I'll press 1, 2, and then once it is completely, the suture is deployed, it will give a hard feeling. So now I come back to open position, and I'll unheal the helix, take the helix inside, lock it. Now I'll open the 2 jaws, and as you see here, the first suture is deployed. Now I'm going to close it under the endo view so that I don't grab the tissue. And now I'll straighten the scope. As you see on the fluoro, I am straightening my device. Dr. Asif has straightened his pediatric scope. So now I'll show you what we have done earlier, rather the starting point. So now I'm using the same pediatric scope. You don't have to change the scope really. I'll go and intubate, go beyond the G junction. I'll just go into the fundal area and then suck out the fluid so that we'll have a better view when I go for the second pledget. So I can also show you the first suture which has been deployed there. So now I'll go beyond the pyloric area and then position myself there. So this device also has got a inbuilt, within the device, you get a Savary Gillard kind of a metallic guide wire, which is used to put it inside, and on this, I'm going to railroad the GERD-X device. So let me go in and then push the guide wire inside. You can also see the fluoro picture there, how the stomach is being inflated and then the wire is in position. Okay, you can go to the end of view, please. So now, on this metallic guide wire, I'm going to intubate and then push in the GERD-X device and railroad it. You can show them the externally. So this is the distal end of the device. You push the guide wire and you can show them my finger movements. So on this, there are two openings here through which the device will be railroaded on. And once the guide wire is completely inside the device, I'm going to go near the patient's oral cavity. You can show them externally. So you see here, once I am at the position where the patient is supine and intubated, so I'm lubricating it with castor oil, or you can use any of the local oils. And as you see here, Dr. Harnath is giving me assistance by extending the neck. And I gently push it down. You can show them the fluoro also. Yeah, as you see here, it's smoothly traversing. The advantage of this device is there is no injury because the distal ends are made of silicone, and that's the reason why the mucosal injury is absolutely zero. So now I'm going to irrigate the channel with simple normal saline, and then the pediatric scope or the ultra slim scope will be pushed through the accessory channel what this device has. Can you do it? So Asif is going to push it, and as you see on the screen, you can see how it is being navigated. And you don't have to use fluoro all the times, but only because for the demonstration purpose, we are using it quite often. So you see here, the scope has gone beyond into the stomach shadow, and now I can see the tip of my device. Can you push in? Yeah. So I'll be going to retroflex along with that. Asif also is going to retroflex. I'll retroflex in such a way that I position myself at the GE junction. Okay, good. So can you just push it? So now I'm going to repeat the same as I have done the first suture or the pledget on the greater curvature side. I'm going to position myself. So I'll cover the other part of the GE junction, and then I'll push the helix inside. Okay, lock. Can you clear the bubbles? Yeah. So now I'll go to the close mode and then close it. So now I'll take my time for half a minute. Can you just inflate now? Because I have to be sure that I cover the full 3/4 of the circumference, and then the GE junction is on the lesser curvature also is being covered. So let me just have a rotation of the device and then see. I think I'm good to go. So now once I feel that I'm in a position, I'm going to go to the fire mode and then fire it. Once it is done, I'll release the helix, take it inside, and open the jaws. So as you see here, there's a nice fundal wrap which is being created, and this is a gastric fundoplication, unlike the TIF, which is a gastroesophageal fundoplication. Can I have the upper GI scope? So this is how the procedure is done. Its maximum takes around 15 minutes. And as I told you, the selection, the other scope, upper GI scope. So the selection criteria is very important to choose and to have a good positive outcomes. We'll just show in a half a minute how this wrap looks like once we put on the upper GI scope and see.
Yeah, I can see it's a really nice demonstration. So first, I'd like to ask the suturing that you apply, the plication is over the greater curvature side, right? So
Yes.
your planning is actually to enhance the development of the GE junction valve and to tighten it.
Yes.
And so how many plication you usually apply
See, Professor Jain, because it's what we select is Hills grade 1 and 2. By and large, 2 plications are good enough to do.
I see.
Very, very rarely we do the third one, but 2 are good enough.
Okay, I think, Rakesh, that was a great demonstration. What we are doing, Philip, is mainly on the greater curve. There are some who are actually an Australian doctor who's doing it on the lesser curve, and there's going to be a study which we want to plan, comparing lesser curve with greater curve. It's going to be a difficult study because it requires a large number of cases to do this. But most cases too, but sometimes on the lesser, greater curve, we use 3 also, especially with hills like Rakesh said, is grade 3. So these patients, of course, would do symptomatically very good. And after 1 year, 70% of them don't require PPS. But I think, like Rakesh said, case selection is very important. So meanwhile, to give an update on the previous case, we did a laser, fragmented the caliculae, and also we'll wait for the biopsy report, and most likely, like James said, looks like an inflammatory thing, and patient's treatment would be completed just with this.
Well,
I think your time is up. Yeah, Philip, time is up. 2 cases only we could demonstrate. We'd like to thank you for giving us this opportunity. It's always a very big pleasure to not only transmit to Hong Kong, but hopefully to be there also.
Wow, Nagi, you are really, really quick, and you already completed the laser lithotripsy and taken it out, so it's really quick.
Yeah.
And thank you so much. And of course, as I mentioned, we miss you and the team from Hyderabad. And definitely next year, I believe that you should come to Hong Kong in person.
Yeah, definitely. So thanks a lot, Philip and James, for this opportunity.
Okay. Thank you, Nagi. Thank you again.
Thank you so much.
Thank you.